Everyone. Dr. Tom Nabby, Dr. John Santana, Michigan Center of Regenerative Medicine tonight. Thanks for joining us. And tonight we were going to talk to you guys all about our approach to patients with hip pain and how we incorporate regenerative medicine into those treatment options. I think it's about time. We can go ahead and get started, but we like to keep these relatively informal and give you guys an idea of how we approach our patients, how we interact with our patients, and then again, how we incorporate regenerative medicine into treatment options for patients when we're talking to them about what they can do to help feel better and function. So with that, Dr. Santana, if the patient were coming into you and specifically saying that they felt they had a hip issue or they were having hip pain, what's some of the first things you want to know about their condition, or you might ask them in follow-up questions?
Yeah, so hip pain is one of these things that we often see in the office. So it's probably like the third or fourth, diagnoses that we kind of see. A lot of the patients that we see here in the clinic are, normal people like you and I who are weekend warriors and like to do things more, active over time. And the hips is one of these areas in the joints that gets affected when you're like a runner or a jumper or do one of all these types of activities. So when somebody comes in with hip pain, the first thing I always ask patients is there like an incident or a trauma that kind of caused the pain? So that usually kind of narrows it down, whether it's more of a traumatic issue or is it more of a wear and tear degenerative type issue. After we kind of tease that out, the next thing I ask them is, where is the pain? So the hip is it's a ball and socket joint. So the hip ball is fitting inside the pelvic socket. So it's a three-dimensional figure. So you can have pain in the front part of your hip, the side of your hip, or the back side of the hip. And all those different things can mean different things depending on what the diagnosis is. So between knowing what caused the pain, how long has it been going on, where the pain is, and then the next question we ask is, what makes the pain worse? Is it a certain activity like running or jumping or walking, or is standing painful on its own, or is it painful when you start getting up from a seated position, or it's only painful when you're rolling to your side or something like that? The other things that we ask too is the pain going anywhere? Does it go down to the leg? Does it stay in that part of the back? Is it related to, like a pain in your lower back as well, or pain in the lower part of the butt area? The next thing I like to ask too is what makes it better? Is it medications like Motrin or Tylenol or things like that, or aspirin, or rest is enough to take care of the pain? Or if you use ice or heat, that's helpful. Or they've tried physical therapy, acupuncture, chiropractor, all these types of things. So just trying to get a pretty general idea of where the pain is and how it started and how it evolves and kind of how it affects your day-to-day helps us figure out exactly where in the ball and socket joint is the problem.
Yeah, it's like a big puzzle we're trying to put together. And each of those bits of information are an important piece of that puzzle. Something we call the differential diagnosis. When we're listening to you tell us about your condition, there's different thoughts going through our brain. Could it be this? Could it be this? Could it be this? And then we'll ask actual follow-up questions to what you tell us to try to either highlight ones that we think it is or maybe eliminate others where we don't think it is. And one of the things that pops up on my differential diagnosis list when somebody comes in with hip pain is what I call the other hip joint. So there's the ball and socket hip joint. And we want to ask certain questions about the ball and socket hip joint. And then there's the joint where the spine meets the pelvis. It's on the back side of your hip, the sacroiliac joint. Mm-hmm. So there's a lot of questions we'll ask that might really relate more towards sacroiliac pain versus ball and socket joint pain. Or is it a spinal stenosis, a pinched nerve in the neck or in the back, going down in the legs sometimes can mimic and present as hip pain.
Yep.
Lack of blood flow can sometimes present as hip pain if you have arterial stenosis or clots in your arteries that are not allowing blood to get down to your butt muscles. Certain activities can cause, like walking upstairs is the only time I get pain. I don't get pain when I walk downstairs. To me, that speaks to it. Oh, maybe this is more of a blood flow thing. So it's important to bring all of those bits and pieces. And, when we're asking you questions, we're not just trying to be annoying. We're actually trying to follow up with specific things in our head. to try to hammer home on what the source of the pain is.
Right.
That's the number one goal of the consult, is to really make sure we know where the pain's coming from. Because if we don't treat the right structure, whether it's a cortisone injection or a stem cell procedure, we're not going to get a good outcome if we're injecting the wrong thing. So
yeah.
There's some diagnostic stuff we can do.
Yeah, so there's a diagnostic stuff we could do. So, here in the office, we have an ultrasound. So we're able to actually evaluate, parts of the hip and the pelvis in order to kind of see where the structural problems may arise. A step to that too is you can get an X-ray if we're looking more of a bony abnormality, something like osteoarthritis, or something like that would be related to that. Or like Dr. Nabby said, if it's a sacroiliac joint or a sacroiliitis that's happening in there, or something in the lower back is affecting it. And then, as another further step to that is we can always do an MRI or a CAT scan to get really further deeper down into it too. So not to, belay the point, but that part of the lower back and the hip and the pelvis is a very complicated area, right? So that's where your center of mass is in your body. So a lot of forces travel through there. So there's forces coming from your legs that go hit that part of your pelvis. There's some side-to-side forces that gets affected by it too. So a lot of times the pain in that area, it's kind of hard to diagnose because it could be contributed by multiple things, like your spine, your SI joint, your hip. For females, you can have a lot of pelvic pain issues from the uterus or the ovaries and things like that. So it's a really complicated structure, and the better the history is that we can get from patients, it kind of makes our job a little bit easier, so we can really pinpoint what's going on. And then, like Dr. Nabby alluded, that's probably one of the most important parts of the appointment is during the consultation, is to see what is the source of the pain, so that we can decide which treatment plan is going to be appropriate. Is it something that we can help you with, or do we need to ask some of our other colleagues for assistance?
Yeah. And before we, move on to treatment, just one more, just piggyback on what Dr. Santana alluded to with the ultrasound machine. Both Dr. Santana and I are physiatrists, physical medicine rehab specialists. So part of our training is really the physical exam, doing specific maneuvers and seeing if does this cause a pain, does that cause a pain. And then both of us post-residency picked up diagnostic ultrasound. Our society has really promoted it as something that fits well within our physiatry scope. Both he and I have tested out and taken courses to learn this skill and really have a specific skill that makes us relatively unique, in that not only can we do these physical exam maneuvers where we're moving your hip around and we think it looks like something, we can actually pull our ultrasound machine and say, hey, this is what I think it is, and then put the scope on there and actually see it and show you. So it's really nice. Point of care right away. We don't have to write a script. You don't have to go away, get an MRI, come back. It's something we can do on the day of your appointment. And it really, really helps us from a diagnostic standpoint with certainty that we have the right diagnosis, and then can move on to, all right, now here's what we can do about it.
Right. And just kind of piggyback on that with the ultrasound and the image guidance with X-rays and things. So being knowledgeable on the anatomy and being able to find that on diagnostic studies like the ultrasound and the X-ray helps us with guiding the needle to where we need to put the either PRP or stem cells or a steroid or whatever medication we're going to use into the structure. So by knowing exactly where the safe areas are to go to deliver the right medicine in the right spot, makes a big improvement on the outcomes.
Sure. So let's say I'm a patient, come in, you diagnose me, I've got hip osteoarthritis. Most common thing we're going to see. What kind of treatments would you outline for me?
So a lot of times, by the time they see specialists like us, they've already seen their primary care. Most of our patients have already gone through the whole resting it and icing it, and they've probably tried over-the-counter Motrin and naproxen or Aleve and stuff like that. They may even have gone to physical therapy and the chiropractor. So by the time they actually see us, most patients have already tried all these things. But if you haven't, that's fine also. You can always go through the more conservative part. So we both like to do the least invasive things first. So the easiest, most conservative things that we could do to try and get you better is what we try and promote first. If that fails, and that's when we start moving up on the algorithm and try and get more aggressive with our treatment. So for somebody that comes in with osteoarthritis, they've already tried a lot of the conservative management treatments that we would normally recommend. We can order imaging to kind of see what else could be going on. And if once we've diagnosed that it is and confirmed that it's osteoarthritis, what we can see, one of the things that we could do is we can do an image-guided steroid injection to the spot just to confirm what we're seeing. A lot of times that confirmatory injection can also be therapeutic, because that could also be enough to just relieve your pain, hopefully get you to move and function better to the point that that's all you're going to need treatment-wise. And then if that doesn't work, then there's other things that we can do too within the realm of traditional medicine that insurance covers. We can do nerve blocks, radiofrequency ablations, things like that. And then if that all fails, then that's when we start the conversation between a surgical consultation, or is it something that we could address with regenerative medicine? Right?
Yep. So I was kind of break mine into two different pathways. There's the pain pathway, and then there's the regenerative medicine pathway. And the only reason we tend to always go, or not always, but we tend to lean towards the pain pathway first, because right now that's the recognized standard of care. That's what insurances cover. Not everybody, but most patients want to try what their insurance is going to cover first before they go into something that's out of pocket. The day I think that becomes the regenerative medicine becomes an insurance covered option, I think our algorithm switches.
Yeah.
It's always better to try to regenerate and fix the problem than just mask the pain. Pain's a privilege. Pain's your body's way of saying, hey, something's wrong, back off. And if all we're doing is a cortisone shot and we're blocking the pain, really we're just allowing you to go out there and do damage and not feel it. And the reason is because the next step is replacing the hip anyway, so might as well damage it more before you're going to replace it, get some more use, get some more mileage out of it, until regenerative medicine came along. And now we got to take a step back and really think about that.
Yeah.
Is that really the right thing to be doing to just, and these are conversations we have with you in the room, and this is an individual. I'm not saying that it's not right for some people. For some people, it's the right decision. For other people, boy, the right first thing to do is, why don't we try to regenerate the cartilage before I go damage it more?
Yeah.
Wouldn't that make more sense? And yeah, it does. It's just, your insurance doesn't look at it that way yet. And we're working on that. We are participating in studies here. We're actually seeking out contacts in the insurance companies to show that if you do regenerative medicine like we do here at Michigan Center of Regenerative Medicine, it works an acceptable percentage of the time. Nothing in medicine is 100%. We're not going to sit up here and say that what we do is 100% effective. But for our properly selected hip patients, given a good quality PRP or a good quality bone marrow procedure, we're seeing, I'm going to ballpark at 70 to 80 percentile recoveries. Really, really good outcomes. We're tracking those outcomes. It's definitely coming, but talk a little bit about what those regenerative procedures look like. What kind of options would you give patients for a hip osteoarthritis?
Yeah, so under regenerative medicine, the top three things that we do here with regenerative medicine, you always want to talk about prolotherapy, PRP, which is platelet-rich plasma, or bone marrow stem cells, right? So PRP is probably the most basic of the three. It entails injecting an irritant, usually sugar water, to the area. Prolotherapy. Yep. Thanks. Yeah. So it's you inject an irritant to the area and causes an inflammatory response. It works. It works well. The problem with prolotherapy is the inflammatory response is really short-lived. So we typically end up doing a few of these injections over time to get a significant improvement in the outcome. The next step to that is something called PRP, or platelet-rich plasma. The idea with platelet-rich plasma is you're using the platelets in the blood to try and attract healing factors and growth factors into the area that you wanted it to heal. It's a really good treatment compared to prolotherapy, because instead of using external irritant, you're using your own innate inflammatory markers and responses to get that effect that you want. The next step to that would be a bone marrow stem cell. So as the name implies, we harvest the bone marrow from your pelvis. It sounds a lot more painful than it is. Actually, a lot of our patients are able to tolerate really well. On a scale of 1 to 10, most patients would say it's about a 3 to a 5. Most of it, it's after we've numbed the area out really well, it's more of a dull pressure sensation in that area. It takes away the sharpness of it, but it's just a really sharp, like a really dull pain. That's kind of when you do that harvesting. Really well tolerated. A lot of patients would always remark that it sounded worse than it actually was. So
I can attest. I've had mine done. It wasn't painful. The worst part is just that strong kind of suction cup feeling. I put it as a 2 out of 10, but most patients put it a little bit higher.
Well, you're tougher than most, so that's good. But anyway, so when after we harvest the stem cells, we can then inject it there. So typically for the hip in particular, because it's a big joint, it's a weight bearing joint. A lot of times, I would lean more towards stem cells for this treatment, because from what we've seen is that the stem cells are more robust and more a better treatment for these types of big weight bearing joints with bigger injuries and stuff like that. So I usually try and talk the patients into doing and leaning more towards the stem cells as the better choice between prolotherapy, PRP, or stem cells. It's obviously the decision is not just a straight kind of decision, because there's financial implications with that as well. That pattern of prolotherapy, PRP, and stem cells also has a price gradation where the stem cells are more expensive. But if the goal is to try and maintain function and heal the joint and get you moving better, the stem cells are definitely a better option with the hip.
Yeah, I look at vascular structures, things that have a very good blood flow, tend to do better, or not better, but they do well enough with PRP. Things that don't have a great blood flow tend not to do as well with PRP. And the reason is PRP works by injecting a signal that tells your body to send stem cells to the area. And those cells need a highway. They need somehow to flow there and migrate to the structure and follow the signal. If there's no good highway there, there's no good blood flow, they can't really get there. These stem cells work by what's called a paracrine effect. They really tell the other cells around them what to do. So they need to get into that structure in order to have their effect. So structures like the osteochondral or hyaline cartilage on the end of the cap of our femur doesn't have a good blood flow. So if you go get the cells, concentrate those, and then put them directly into that cartilage, then you're going to get that paracrine effect that those cells have. So it to me, it breaks down to severity of disease, vascularity of the structure, osteoarthritis of the hip. I always recommend bone marrow. It's not that PRP is not going to give you any relief, but it's just not going to get that cartilage growth, which is where you're going to get that long-term benefit, which is a big follow question we get. And when this stuff works, how long does it last for?
Yeah.
And definitely a stem cell is going to last longer than the PRP.
Yep. The other thing too, with just kind of looking at that structure too. So the other thing that, are you done with the hip?
Yeah.
So the next structure too, like we talked about a little bit, is the SI joint or SI joint dysfunction. So for the SI joint, even though it's the same general area as the hip, the pain is somewhat the same too from how you present. That one I actually gravitate more towards PRP. Same. Kind of like what Dr. Nabby says, because that SI joint you do have some joint there that you have to manage, but for the most part, majority of the dysfunction is actually related to the ligaments that's holding the joints together. And because it is a very vascular area, PRP really works really well for ligaments type issues. So I usually gravitate more towards PRP to that.
So do I. Yeah. Same idea. The other issue that can develop hip pain is on the outside of your hip. Greater trochanter bursitis is oftentimes it's called. It's not really a bursitis. It's kind of a misnomer, but it's a thickening of tendons that are attaching there, tendinopathy rather than a tendinitis. And PRP works extremely well for that.
Yeah. Usually we would know that a patient has a trochanteric bursitis if their primary reason for coming in is that every time they roll over to their side is they can't tolerate it. So that's a very common presentation that we see for the trochanteric bursitis. The exam is actually pretty straightforward with that too. We just poke at that bone on the outside part of your hip, and if that hurts a lot, then we know we're on the right spot.
Yeah, a lot of our diagnostic tools are just, does it hurt here? So a lot of ground we covered tonight. We try to keep these relatively short and sweet, not diving too deep into the weeds of what regenerative medicine is, what the science is. We have a couple other podcasts we've done where we do that. If you want to check out our YouTube channel, you can find those on there. We'll be doing these every month and new topics every month. We like to try to leave a little bit of time for questions. It's been close to a half hour. That's where we try to leave these. So if you have any questions, feel free to put them in the chat box. Looks like we had a couple come across. One we touched base on a little bit already. Bone marrow sounds painful. Again, I can attest to it's not. The way Dr. Santan and I do our procedures, one, we use ultrasound or X-ray guidance. We can see our target. We can numb everything between your skin and the target. The real pain comes from going through the bone to get to the bone marrow, and so we numb the outside of that bone, the periosteum, with lidocaine. And then we like to use nitrous oxide, laughing gas, which is a dentists oftentimes use to help take away the anxiety, take away the pain from the procedure. When done with those things, it's really not a terribly painful procedure. Another question. Avascular necrosis.
Oh, so avascular necrosis. So before regenerative medicine came about, avascular necrosis is one of those definitive diagnoses that you do need a hip replacement. It's almost a shoe-in, right? So it's avascular necrosis means that the degeneration has gotten so severe that the impact of the socket into the ball is causing death on the surface of your femoral head. So when you get an MRI of that, you do see a big inflammatory response just underneath the bone, inside the bone in the femoral head, and it's degenerative. So with regenerative medicine, we've found that we can do a technique where we can actually deposit stem cells right into that femoral head of the bone and actually try and nourish that bone from the inside. So the regeneration happens from inside the bone going more outside to the surface, and therefore addressing that severe degeneration on it.
Yeah.
So it's a very cool technique. It's not a lot of physicians, I believe, know how to do this properly, and it's one of the things that we've trained on extensively and have found really good results with it.
Yeah, we actually have had good results with that. It is a different injection technique, as Dr. Santana alluded to, a little more technically challenging, and the idea is it's essentially, rather than fertilizing the tree by putting fertilizer in the leaves, you're actually sticking the fertilizer into the root and stimulating the growth from the inside out. So I like that analogy.
Yeah, it's a good analogy.
Let's just take one more question here. And what's the indication for labral tears?
So labral tears, typically the presentation of the labral tears is very similar to somebody with osteoarthritis, right? So it's typically related to wear and tear type things, to kind of tear that labrum that's kind of holding that ball and socket in place. So I still would recommend stem cells for that, because it doesn't occur on its own. Usually when something has a labral tear, you do have some degree of osteoarthritis happening in there as well. So I typically would recommend stem cells do that too.
Yeah. One of the things I like to watch for if anybody has a labral tear, to make sure they don't have a cam deformity, like a deformed cup. So the ball is the head of your femur. The cup is your acetabulum, which is part of your pelvis. If you have a deformity in your acetabulum that's leading to abnormal stress being put on your labrum and subsequent osteoarthritis, regenerative medicine, we can heal that, but it's probably going to keep recurring if you don't get that surgically fixed. So that's one of the things that I do try to look for as far as a patient that I might steer towards a surgical fixation first, maybe even a arthroscope. Doesn't have to be total hip replacement, and then potentially fixing any residual deficits after that.
Yeah.
One last question that came across, risks. So common question we get: what are the risks of this procedure? It's your own cells, so you can't be allergic to your own cells. You can't reject your own cells. Infection, we use sterile technique when we're aspirating, when we're processing, when we're injecting, to reduce that risk. If you were to get an infection, the nice thing about these cells is they do have an antimicrobial effect as well as a trophic growth effect. But the antimicrobial effect will decrease that risk for infection. And we're not using any hardware. So should you get an infection, it should be very treatable with oral antibiotics. You shouldn't need to have any kind of surgery to debride it or any kind of treatment, knock on wood. We haven't had any infection issues here, but that's always a potential risk. And then the final risk would be needle placement. So making sure you're going to people who know how to drive needles. Both Dr. Stanton and I are both interventional pain specialists, trained using X-ray and ultrasound guidance to not only hit our targets with needles, but also avoid the things we don't want to hit.
Yeah. So thanks for joining us. I know it's kind of late that we started today, but I appreciate anyone that kind of hung in there with us with this late webinar. We're going to have replays of these. Just watch your emails. If not, it's going to be available on our YouTube channel. If you have any other questions, you could always go to our website, regenerativemedicinemichigan.com. We have a contact page on there, so you can just send an email to me or Dr. Nabity, and we'll be able to answer your specific questions. If you want to discuss your case in particular and want to come in and have an appointment, you can call the office. The number is 248-216-1008. Again, that's 248-216-1008, and we're more than happy to kind of see what we can do to help you.
We also do telemedicine if you're someone who's maybe tuning in from a little ways away from the office and don't necessarily want to drive all the way for your consult. We'll review your images, have a telemedicine conference with you over the internet, and then should it be something you wish to have done, obviously you need to come in the office to have the procedure done. We have plenty of those patients as well.
Yep.
All right, everybody. Thank you so much, and have a good night.
Good night.